Hello, everyone. Thanks for joining us. We are going to have a conversation today about the maternal health crisis in the United States and where there are opportunities for innovation. I'm Stephen Collins, the CEO of Matter, a healthcare technology incubator and innovation hub with a mission to accelerate the pace of change of healthcare. In addition to hosting conversations like this one, we run an incubator for healthcare startups. We've incubated more than 850 companies since we launched in 2015, companies that together have raised more than $5 billion to fuel their growth. We also partner with established organizations such as health systems and life sciences companies and payers to strengthen their innovation capacity. We run 8 to 10 cohort-based accelerators each year together with our partners that focus on specific topics. We are currently running an accelerator focused on the maternal health crisis together with a terrific group of partners: HCSC, Laerdal Million Lives Fund, University of Chicago Medicine, Parkview Health, BayCare, Stryker, and Organon. Every startup who participates in the 12-week program will receive $125,000 of cash and services. Applications are open through February 4th. There's a link for more information in the chat. And towards the end of the program, you'll have an opportunity to learn more about the initiative. But why all this attention? Why are we focusing on maternal health? And the answer is that our outcomes in the United States are horrible. They are dramatically worse than every other developed country, and they continue to get worse. More than 10 times as many women die as a result of pregnancy in the United States than in some other developed countries. Maternal mortality in the US is now the highest it's been since 1965. To shed some light on what's going on and what we might be able to do about it, I'm joined today by two leaders that come at this issue with different perspectives. So Colby Holtzhaus is the head of the global medtech commercial organization Organon, the life sciences company that spun out from Merck in 2021 and that focuses on women's health. She previously led Organon's maternal health business. She ran a startup focused on postpartum hemorrhage, and she's on the board of another technology company now that is also focused on women's health. And Dr. Ira Seitz is an OBGYN and the medical director of women's services at BayCare, a leading health system in Tampa. It's a health system we've had a long-standing relationship with. He's been practicing at BayCare for 13 years and is involved with a number of both national and state policy bodies focused on women's health. If you have questions for either of them, please drop them into the chat. I will weave them into the conversation as appropriate. Following our conversation, my colleague Casey Sheridan will provide a brief overview of our maternal mortality accelerator. And with that, let's get started. Colby and Ira, thanks so much for joining us. Really looking forward to this conversation and wanted to get started on sort of a personal level with your journeys and how you got into this space. Colby, we'll start with you. How did you come to run a company that's focused on maternal mortality and then leading the area at Organon?
Sure. Thanks, Stephen. Thanks so much for having me and the important work that you guys are doing with this accelerator. We're so excited to partner with you. My personal journey, I've worked in medical technology my whole career. There were a lot of happy accidents that led me into this space. As a history major, I kind of have no business working in medical technology, but it's an area where if you can see an unmet need and you can interact with healthcare providers and hear their challenges, then you can work with engineers to solve them and bring them to market. So it's been a really fulfilling place for me to spend my career. I started in sort of more traditional med tech areas like cardiology, but have found my way to women's health. And then most recently, specifically to maternal health, which is an incredibly fulfilling, if sometimes emotionally challenging place to work because the unmet needs are so significant. The barriers to changing the status quo and changing care are so significant. And yet, if you can make a difference, there's a very, real strong emotional return to helping a family at their sort of most vulnerable moment when they're bringing a child into the world. So it's been a really special place for me to work.
Ira, how about yourself? You're leading women's services at BayCare. How did you come to obstetrics and gynecology? How did you end up doing what you're doing?
Yeah, and thanks again for having me as well. Um, Obstetrics and gynecology, really, if you ask me seriously, I probably was born out of having a very close relationship with my mother when I was a kid. I think that's probably the gist of it. Um, as far as getting into, this women's services role, I'd always kind of looked at these issues from that broader sort of more public health perspective, and I've always been interested in kind of developing interventions to improve these outcomes. I think what really happened that was key for me is when in 2013 I joined the OB hospitalist group, and that completely changed my day-to-day schedule. I ended up with a lot more free time during the week, and I was able to be that guy that was able to be involved in a lot of the quality improvement projects in our system. I was kind of always just on all the meetings and leading some of these efforts. And after a few years of kind of doing it for free, they offered me a job. So here I am.
So there it is. So the the state of maternal health, Colby, in the US is horrible. Um, it's, as we were talking earlier, it's, I find it at least intellectually fascinating, but it's emotionally wrenching to when you dig into it and understand what it means for women. Um, how has it been changing over the last decade? Is it getting worse? Is it getting better? And why is it the way that it is?
I suppose that if I could answer the question of why it is the way that it is, if any of us could truly answer that, then maybe we'd be further along in solving it. But I'll give you a few thoughts nonetheless on how we got here. And my overall answer would be that we are definitely moving in the right direction, and in part because the past decade has been a story of awareness. I had no idea that we had a maternal mortality crisis happening in this country. And in fact, some of the early work at even just counting maternal deaths and doing that in a systematic way has only begun in the past 20 years. And there was a big initiative here in California from the California Maternal Quality Care Collaborative, one of the first organizations to systematically work with hospitals to collect data and then to try to create protocols for care to say, how can we standardize our approach to addressing complications in childbirth, and see if that could make a difference. And some of those seminal publications, which were, not just from California, but other physician leaders around the country in the maternal fetal medicine space, collaborated to start to raise awareness around maternal mortality, but also maternal morbidity. So, we have far more women die in childbirth than should, obviously, and that do in other developed countries. But our rates of morbidity, which would be, hysterectomy, massive transfusion, staying in an ICU after childbirth, some of these other events that happen also happen at unacceptably high rates. And just beginning to measure that as well has been a really important step in trying to address solutions. And part of the solution is standardizing care, saying, okay, we all need to have the same plan when we go in to deal with an emergency. We need to have a plan, a protocol. We need to have a cart, a crash cart that looks the same, has all the right tools on it. And we need everybody to know what their role is in managing that complication. And that means training and drills and simulations. And all of those efforts have been rolling out over the United States over the past decade. So where 10 years ago, maybe not everybody had a cart, now the Joint Commission, which accredits hospitals, comes in and checks and makes sure everybody has a hemorrhage cart. So those are amazing strides. And I think maybe some of the data, we haven't necessarily seen the huge strides that we'd like to see. But the effort is moving in the right direction, right? We have the right sort of plans in place. And I think even, for example, Joint Commission has said, okay, well, we've come out with our sort of first set of recommendations, which we're auditing too, but we're going to evolve those and continue to support hospitals in their efforts to improve care, improve the efforts, in the acute setting. There's also, morbidity and mortality that happens before birth and after birth. In the, maternal mortality is any mortality within 12 months after childbirth. So there's also a crisis in women dying at home after childbirth, which is harder to control for in the care setting and gets into some of the more challenging aspects of moving the needle, addressing social determinants of care, of social determinants of health, helping women get back into the hospital. And again, some of the big changes like seeing Medicaid coverage for women postpartum out to 12 months. A decade ago, that didn't exist in most states. And now I think 43 of 50 states have Medicaid coverage out to 12 months, which is really a remarkable and important change. I could go on, but I'll stop there.
I love that perspective when you add those things, insurance, technology, services, innovations, awareness, data, a bunch of things that you're pointing to that that as as they get embedded a little bit more, suggest we may turn the tide, which I love that and appreciate that. The data that we have out today is shows things getting, it's really only through 2021, I think, and shows it getting worse. Ira, you're on the front lines. You're in your practice, are you seeing anything that would suggest that really contributing to these worsening outcomes, or I guess conversely, some of the changes and dynamics that Colby mentioned, are you seeing those as taking hold, or optimistic about the ability of some of these changes or others to turn around the trajectory?
Yeah, I think that, when, like Colby was saying, when we first started getting the data, I think a lot of us Americans looked at it and thought, why are we not the best? Like, why are we doing so poorly? We've certainly put a lot of money and time and effort into this, and then, when COVID-19 hit, that's when we really started seeing the sharp increase that a lot of people are talking about right now. I think when you look at it overall, I agree. It's multifactorial. It's a lot of these things coinciding together that seem to be worsening outcomes. Comorbidities for our patients, their structural, economic, and political factors. There's issues with cultural and race-based, treatment that are causing negative outcomes. And all of that was going on before the pandemic. When the pandemic hit, yes, there was some, maternal deaths that were directly attributed to the viral infections, of course. But what we really noticed was that a lot of those more structural issues were exacerbated during that time. We had people that had difficulty accessing care. Sometime in the beginning, the offices were closed. We were kind of doing limited prenatal care. We had people that had disruptions in their employment status, which led to disruptions in their insurance status, which further exacerbated accessibility issues. So you see there's a lot of that underlying stuff going on that is contributing to these outcomes that we're seeing. So I agree that, like she said, there's some glimmers of hope. I think that we have made some strides, especially in the inpatient space, and trying to shore things up. But at the same time, I think that we still have a long way to go, even in that space.
Yeah, a long way to go. And you mentioned some of the racial gaps. Colby, what can you tell us about the differences? As bad as things are generally, the data for women of color is worse. What can you share about the different demographic groups, and and why outcomes may vary among them?
You're really giving me the hard questions with these whys. Why is society the way it is? And I definitely think that Dr. Seitz will have a lot to add to some of the medical considerations here. But the outcomes are different for maternal complications the same way that they're different in many other health outcomes. And there's a combination, and some of the factors are certainly controversial and yet very well published and well researched and well documented. So we can see there's differences in underlying chronic conditions, which can make any medical procedure more challenging. If you have underlying chronic condition, then going through pregnancy and delivering a child is going to be more complicated. And then, why does that happen? There's, certainly social determinants of health, and then there's just implicit bias and unconscious bias that exists in our society as a whole and exists in our healthcare system and exists within, individual providers who grew up in a system that carries bias with it in its training. And that the fact that it's unconscious makes it particularly difficult to grapple with, because it's hard to know if you're, the way that you're approaching patients is actually different. You might not even perceive that you're doing it, or that your system is sort of perpetuating a different approach. But certainly there can be a difference in how concerns are heard or listened to by a healthcare system that has different expectations of patients based on how they show up, how their skin color looks, and how they appear in clinic. And if you are presenting with warning signs that could be interpreted in multiple ways and they're not interpreted in the most serious way, that can be incredibly risky for a pregnant woman or a postpartum woman. So that's my layperson's interpretation of what we're learning in the space. And they're particularly difficult, challenges to grapple with as a healthcare system, I think.
Ira, how do you navigate that? What are you seeing on the front lines? Is it, the interplay of societal attitudes and cultural factors that influence maternal health outcomes? Is it just a question of training for, physicians and clinicians that, have you seen anything that, or done anything in particular BayCare that makes a dent in the demographic discrepancies?
Yeah, I think that on the day-to-day, on the front lines, it's a difficult thing for many of us to recognize. It's hard for us to see when these types of things are affecting the outcomes. It does become very black and white, though, when you survey your patients and you see that your patients say that they feel like they were treated differently because of their skin color. I mean, it's an eye-opening thing, I think it seems like the state of things in many institutions is that many institutions haven't even tried implicit bias training yet. I think it's a great place to start. I think it starts to help you really gain an understanding that the problem does exist, but I really think it's the work after that really is where the insight comes. I think most of the eye-opening experiences that I've had have happened just talking directly with my patients about it. It's hard to really, when you come from a completely different walk of life, it's hard to preemptively think what they're concerned about, what they're worried about, and what they're not communicating with you. And, where's that mismatch going on until you just openly and honestly talk with them. And then when they explain it to you, you're like, that totally makes sense. I just never would have kind of gotten to that, So having those interpersonal connections with folks from different walks of life, I think, is where the breakthroughs come from, and practicing that is it's definitely necessary.
And did somebody like teach you how to do that? Is that just your personality? Do you try to teach others how to do that? Is that something that you can, I guess what I'm asking is that something you can systematize? Or is that a function of who you iricytes are and your personality and if so, how widespread is that among your colleagues?
Yeah, I would say there's definitely a difference when you're somebody who is trying to implement these things and you really have to walk the walk, right? I really got to really embed myself in this if I'm going to ask everyone else to do it. You know what I mean? Um, I do think that as providers, we probably should be taking a more proactive role in being responsible for trying to better our our response to these types of issues. We should be actively seeking this out. One, because it's probably going to lead to better outcomes for your patients. And two, just from a sheer business perspective, I mean, if your patients feel like you're not treating them differently because of their skin color, they're probably going to come back to you next time they have a pregnancy, right? Like it's just good business. But I think a lot of them are just so overwhelmed that they barely get time to read journal articles, let alone like go to these sort of training things. So we've got to find ways to sort of incentivize that good behavior. Um,
And how if you look at maternal mortality, and I can't remember, one of you mentioned this earlier, I think it's there are complications associated with pregnancy that contribute to to maternal deaths. There are complications associated with delivery, and then there are challenges in the first year after birth. Oh, where do you see the greatest opportunity for healthcare providers and professionals to, if you had to pick one of them, where would you focus, and what are the kinds of things that you might say to your colleagues?
you want to go first, Colby, or you want?
Sure. I mean, as a person sitting, I sit within Organon. We have a business which is focused on postpartum hemorrhage, really in the acute setting. So immediately following childbirth. So I spend a lot of time thinking about how we can integrate with programs that are intended to improve that acute care around delivery. From a personal standpoint, I see a lot of room for opportunity, in the before and after. But I'm not as close to those. But I can say that from as we think about how healthcare providers in particular can move the needle in an acute setting, there I have this amazing opportunity with our 100 people that we have in the field who are supporting our product for postpartum hemorrhage, which is called the JADA system. And it's a vacuum system that is used to help the uterus contract after childbirth. So if you've delivered a baby, if the uterus, that muscle needs to contract to control bleeding, right? That is the sort of necessary physiologic next step after delivering a baby in order to cut off the sort of blood supply that was feeding the placenta. And this vacuum can help do that in the setting where the uterus doesn't do it on its own. And so to introduce a brand new technology, a brand new mechanism of action, a concept that people haven't thought about, we've had to go out into almost 2,000 hospitals and teach every single person who touches labor and delivery how to use this new product. And it's been an incredible window into how complicated it is to change behavior in a complex system. So, I used to work in cath labs, and in a cath lab, everything is scheduled. The doctor sort of works with the same techs. They know exactly who they're going to see at what time. Occasionally there's emergencies, certainly, but, a lot of it is planned out. In childbirth, you have no idea what's going to happen at any given time. And there are shifts changing. There's patients who cross over shifts. The care teams change in the middle of a delivery, which is kind of a crazy concept. Like at no point in the OR would the team be like, oh, we're done. and we'll just get a new group in here to finish up this surgery. But that happens in childbirth all the time. And it's managed well, but it creates this need for everyone to be operating from the same playbook. So to reach all these human beings and get a new concept into their head, it takes an enormous investment. So for us, it's just our, single technology, but to change the approach to managing all kinds of complications, implementing a postpartum hemorrhage toolkit, implementing a bundle, requires this dedication to training and simulation. And I've seen, the major societies really get focused in how do we teach simulation. So you go to ACOG, you can spend all day running critical care simulations and learning using complex, fascinating models that are able to simulate a hemorrhage or an embolism, a cardiac event. It's really amazing, the technology that's supporting that learning, but then not every hospital will have access to that. So democratizing access to training, ensuring that low resource hospitals that are typically understaffed and overburdened, that they're able to get their teams carved out protected time for training. Those are kind of policy initiatives that can make a difference. And there has been actually legislation to support creating additional funding for regular training and simulation of emergencies, which is really important. I find it to be a really fascinating area of medicine because the sort of classic see one, do one, teach one doesn't work as well when you have such an unpredictable schedule. You really have to carve out that time separately to learn as a team, as an integrated team.
Such great insights, and Ira, I saw you nodding or shaking your head, and would love your thoughts and perspectives as well. And as part of as you're talking it through, Colby mentioned the medical societies. I know you're involved in the American College of Obstetrics and Gynecology. Is there a particular role there in terms of that they've been playing? Are there other groups like that? But would love your perspective generally.
Yeah, I'll go first about the simulation and drills. I mean, yeah, absolutely. I mean, a lot of these outcomes, thankfully, in our field are very rare. So, an OBGYN may go 5 to 10 years before they find themselves in like a life or death situation. And to think that, the training that you completed 20 years ago is going to make you ready to handle that is, it's naive. I mean, it really is. I mean, we really need to be seeking out these simulation drills. Society of OBGYN Hospitalists is another one that does great OBGYN, great drills. And back to your prior point about before pregnancy, after pregnancy, kind of big areas. Yeah, I mean, we see that a lot of patients are coming into pregnancy with more comorbidities, and many of them are unable to get those comorbidities managed and under control before starting pregnancy because they don't have a payer source. They don't qualify for Medicaid until they become pregnant, and a lot of times, so if we had a way to get some of these comorbidities under control before we started pregnancy, would certainly improve a lot of our cardiovascular outcomes. And then after pregnancy, I mean, if you zoom out your lens a little bit and look at pregnancy associated mortality, where you're lumping in deaths due to overdose from drug abuse or deaths due to suicide from major depressive disorders. I mean, those deaths absolutely dwarf all of the pregnancy related deaths. So having a solution for that would make a world of difference.
Me switching gears a little bit, and Colby, I'll go back to you. You've spent a lot of time working with different health systems in roles that you've had. Are there particular models or initiatives or structures that you've seen either in the US or you've also had experience in other parts of the world that we could learn from, and things that other countries do differently that could help us improve our maternal mortality rates, things that you've seen in pockets here and there, other than obviously implementing the JADA system, pockets here and there that in the US that seem to be real strengths that could be replicated. And then Ira, I'll come back to you and ask you the same question.
Yeah. And I mean, I'll be honest that I'm more of a US expert, although I do now have responsibility for getting JADA out to the whole globe, and we're getting started on that process, which is exciting. One of the sort of biggest differences probably between the US and many, but not all countries is the use of, midwives or doulas, or just a different kind of birth setting for low risk pregnancies. And that's, again, to your point, not universal in the US. There are hospitals that have incorporated midwifery practices into their hospitals. There are hospitals that welcome doulas, and increasingly, there's just actually I think New York State just announced that they'd be reimbursing for doula services. So there's increasing support for, a model that really centers the patient, the birthing person, and can maybe better hear concerns or be listening for things that are going wrong, that are harder maybe to pick up in a fast-paced hospital environment. The hospital environment does kind of lean towards scheduling birth, right? Let's start an induction. Let's, get you on a calendar. Let's sort of keep things moving along. And a lot of those decisions to intervene are absolutely, the right thing for mom, the right thing to, keep the pregnancy or keep the delivery moving at an appropriate pace for fetal safety as well. But there's also just a pace to US healthcare, which doesn't always exist in other countries. At the same time, there are some other countries that have much, much, much higher C-section rates, right? So there are some things that I think the US is doing well. The effort nationwide to try to bring our C-section rate down is positive. Again, varying by geography, but there are some positives. So those are maybe some insights from outside of the US. And Dr. Seitz, I don't know if you also have some thoughts you want to add to that.
Sure. I agree with your sentiment about increasing midwife involvement. I think, just on the ground right now, where there's a total shortage of OBGYNs, with this expansion of OB hospitalists, every new program that opens up every other month is another 5 or 6 docs at each hospital that have to be created out of thin air, So we really, and to be cost effective, we really need to be having midwives managing the vast majority of these low risk deliveries, I think, I'll give you for example, right now in Florida, there's legislation trying to be passed where they're trying to develop these advanced birth centers where, the idea is to put them in rural areas to help with access and allow them to even perform C-sections. I think in my mind, it seems scary being far away from a blood bank and, the major resources that hospitals have. And, we've seen over the years, a lot of the rural L&D units closed due to funding issues. You know what I mean? So, I don't know if we need to reinvent the wheel like that. You know what I mean? But I think that there are other models where we can bring in midwives and try to focus on not being such an interventionist system. Everybody's constantly worried about malpractice cases, but then you do the C-section and then you end up with a bleeder on your uterine artery, and the next thing you know, you got a massive hemorrhage, right? Like it's just this trickle down effect that happens sometimes, you know what I mean? So yeah, I think there's areas that we could definitely improve in how we manage low risk pregnancies, and then keep the OBGYNs, managing the more high risk pregnancies and the more tertiary centers.
How did, as you're talking it and some of the other things that you've said, we obviously we have challenges in the US with healthcare across the board. When you look at rates of obesity, rates of diabetes, rates of hypertension, complications associated with things that I I believe if we strengthened primary care as a general concept and created more access and more opportunities and more the kind of relationships you spoke of between clinicians and patients, which that we might end up with sort of a different trajectory. And how much, in your view, of what we see with maternal health outcomes is derivative of that as a fundamental kind of challenge that we face in the US with just the way our healthcare system is organized and paid for, and kind of where we have so many gaps in terms of access and equity and sort of a less of maybe a nurturing primary care system.
Yeah, I mean, I think we often prioritize the liver transplant versus the prevention of hepatitis C. You know what I mean? Like we would definitely suffer from that. And I think it's really evident in this realm. I mean, we have patients, like we said before, that could have their comorbidities optimized prior to, but then just, even more than that. I mean, yeah, partnering with, athletic, institutions, the YMCA, to increase, cardiovascular health prior to going into into a pregnancy, or social safety net kind of programs after you deliver, where life is difficult when you go home as a single mother, especially if you've just recently had surgery, you've got multiple medical problems. I mean, it's an uphill battle, and um, being just a little bit more cognizant of what those people are going through, and being there for them. I think it's going to require society to look at care in a different way.
Colby, anything to
I
add to that?
agree. And I think, in the end, when you think about the incentives and the economics of the system, a lot of what you just described are, services, early stage services, and there aren't the same incentives in our system to improve basic services as there are to come up with, innovations for later stage complications or challenges. And so that is a underlying problem that we have to grapple with. And in childbirth in particular, the incentives are minimal for industry, I think, to get involved and participate, and that's the hospital services industry and the life sciences industry, because 45% of births are Medicaid births. And so hospitals are losing money on, almost half of their deliveries. And right there, that's a fundamental challenge where they don't see the dollars to invest in improving outcomes. Even if at the end of that investment, there could be cost savings, just getting over that hurdle of the initial investment is so hard. So I do think there's some fundamental challenges there.
I mean, I think that statistic that you just cited, it doesn't tell it all, but it certainly tells a lot of the picture of what some of the kind of structural challenges are that we have in the US of focusing here. What about if you expand beyond just delivery and look at the whole spectrum from pregnancy through to postpartum? Are there, talk about innovations or technologies or engagement methods or, anything that you've seen that you've either seen helping address maternal health outcomes or areas that you think have a lot of potential? And I know, Colby, you're involved in several, and then maybe Ira would love your thoughts on, what you've seen in practice, or even what you would love to see, exist or be implemented, that maybe isn't. Colby, start with you.
Sure. And I'm an optimist by nature, as you can tell by my answer to the first question. I think it's improving even when the data is not there yet. And part of what I think is so exciting right now is that there is a lot of innovation. Often a lot of it very early stage, but some entrepreneurs that have been out there working hard for a decade trying to bring new concepts into the space, and they do really span technology, services, and life sciences. And I haven't seen, in my experience, I haven't seen as many entrepreneurs coming with services ideas as we have now. And that's everything from, Maven, which has achieved unicorn status and, fully entrenched itself into practice, to, smaller companies that are just taking smaller bites at the apple and trying to support specific patient populations or specific insurance classes or specific geographies, and trying to help coordinate care better. A number of technologies looking at monitoring of patients to enable remote monitoring. Dutch sites brought up, maternal deserts and women who have to drive a long way to see their provider. That can be a real barrier to getting good prenatal care. So how can we close that gap with technology? I'm particularly excited about innovative opportunities around preterm labor. That's another gap that where we haven't really seen any new innovation or solutions in a long time. Preeclampsia is a huge need. I can't say I've seen a lot that is out there that can address that, but as there are entrepreneurs in the audience thinking about where to focus, that'd be a great one. I could go on, I guess. And then postpartum care as well, and thinking about the ICU, even thinking about the NICU, which isn't quite pregnancy and maternal mortality, but is the outcome when you have preterm labor is that you're spending time in a NICU with a tiny baby. So how can we do better for those families as well? Some interesting new solutions there as well.
Great. Ira, your thoughts, things you've seen, things you'd love to see that you haven't seen, things you want to invent.
Yeah, I mean, I think I think in our field, we're just sort of, at least in my area, just sort of scratching the surface still of the telehealth situation. I mean, the ability of bringing in specialists, even to rural, remote areas it should be an absolute game changer for people. So I think I'd like to see that, expanded. When you talk about those rural areas, postpartum cardiomyopathy, for example, I think when you look at the data, we have maybe 1 to 2 deaths a year in Florida, for example. And our ER docs are seeing on average like 8 million visits a year. Like it really is trying to find a needle in the haystack, So if we had some way for utilize AI to look at the, labs, vitals, really find that needle in the haystack, I mean, that would be certainly helpful, I mean, a lot of our stuff that we think of as like hands-on, I think, I often picture the person at 2 o'clock in the morning who's dealing with a bad postpartum hemorrhage in the middle of a hysterectomy or something, and could really just use the eyes of some, like a advanced surgeon that's just not available in their hospital. I don't know. Give me some glasses that have a camera in it. They can see what I see, tell me where to cut. What do I do next? Right? Like we can get really creative, you know what I mean? We just haven't kind of gone down a lot of those routes. Another one that there's a system called Perigen that analyzes fetal heart rate tracings, and the idea is to kind of intervene before we have any negative outcomes for the kid. but not unnecessarily increase the C-section rate, you know. What we really need is a randomized controlled trial of do the C-section when the computer says so. So give me the results of that. Can't wait to see.
There's a few questions about nutrition that relate to nutrition. And so, wondering how do you see nutrition as being a significant issue during pregnancy that contributes to poor outcomes for maternal health or I suppose outcomes for the kid, but specifically around maternal health? And then, stepping back from that, are there, so much of healthcare happens outside the clinical setting in, the life environment and the um, how are the other factors presenting themselves when you're seeing patients, and what are the kinds of correlations that you're observing um, between uh, between things like nutrition or housing or education or other of these social determinants and the outcomes that you're seeing um, with mothers that are under your care? Ira, directed to you.
Yeah, I'd say, with nutrition, I mean, just for example, let's just take iron deficiency anemia. I mean, it presents a massive problem when you have a patient that presents with a very low hemoglobin and then goes on to have a significant postpartum hemorrhage, So, and it is very common. I mean, there's lots and lots of patients that present with that, and we've gotten to the point now where we're just kind of bypassing the whole nutrition issue and doing IV iron infusions weekly. We have these people come back and back and back. I mean, and that is a expensive way to deal with that problem, I'm sure. I don't know what the cost of that is, but I mean, I'm sure it's an expensive way. And then the other aspects, yeah, I mean, I think, we see this in multiple outcomes where people with housing instability, for example, I was watching a report the other day where they were talking about infant mortality rates increasing, where people would lose their place that they're staying, might not have a crib in the new place they're staying in and end up co-sleeping and then suffocating the infant. I mean, just it seems like such a simple little problem, but it affects so many other things. I mean, you lose the place that you stay that's near where your doctor is, and now you're an hour away and can't get to your prenatal care appointments. I mean, they're significant issues that really, really do impact, the care that these patients can get.
And have you seen any meaningful interventions, either, clinical or otherwise, that are helping or could help?
Yeah, I mean, I think, we initially go for okay, where's a shelter, nearby that we can get this person into if they don't have housing, and those are very few and far between. I mean, the availability of those is, it's very difficult to get patients into those. Now, that is another superficial fix to the more general underlying societal problem of why is this patient having difficulty with stable housing? What's going on in their work life that is making it difficult for them to not be able to afford it. That's a lot of that becomes like our more societal issues, that are hard for a healthcare person to really solve.
There's a lot of questions that people have asked. We've touched on most of the themes. There's one specific question about the Biden Task Force on Maternal Health, and wondering if either of you have seen any meaningful outcomes coming out of that have helped yet in any particular way.
Well, I think there are meaningful initiatives. I don't know that they've moved all the way to demonstrating changes in outcomes. The policy implementations are important, but are long-term measures. In particular, CMS has been working towards creating a hospital-friendly birthing designation. And this is sort of the first step in saying, okay, we're going to measure the quality of care at, in obstetrics units at hospitals in the US. And the initial, certification is very basic. It's really 2 questions, which hospitals can self-certify, but they're moving towards adding a more impactful quality measure into that certification, which will look at outcomes and, what is your complication rate, your transfusion rate, your IC rate, all these, things that are good hard measures of how you manage complications. And so, again, I see that there's important steps that are happening. It just will take time for those to get all the way out. And of course, the support, like I said, for expanding postpartum Medicaid coverage, I think can be really meaningful and hopefully move the needle to ensure that women get back into clinic and get the long-term care that they need during that, very vulnerable period.
I agree. The aspects of it that are helping to increase access to care is always going to be beneficial. And from the standpoint of, like you were saying, these programs that try to give us metrics and are we doing a good job? As the person for like our system that's going to be in charge of or hitting those marks, if it's a good metric, I absolutely look forward to that challenge, right? That's the piece of the puzzle that we need to solve. I think we just have to be careful about the metrics that we choose. When we say prioritize C-section rates overall, everything else, then you may start to have more bad baby outcomes. And we don't really have a more all-encompassing metric that can show this is quality care. You know what I mean?
Mm-hmm.
So putting all of it together can be difficult, but I absolutely relish the challenge. Like bring me your metrics. Let's do this.
I love it.
I remember learning early on that transfusions are bad, but good, because you don't want to have a high transfusion rate, because then that's an indication of complications. But at the same time, we definitely don't want to discourage transfusions. So how do you manage something like that in a quality system? So, to your point, very complicated.
Well, thanks to both of you for your thoughts and insights. I really enjoyed the conversation. My colleague, Casey Sheridan, is going to come on to now provide a brief overview of 51 Labs, which is our women's health platform. And as I mentioned at the beginning of this program, we are running an accelerator under that umbrella. And so Casey will share a little bit more. Ira and Colby, thanks so much. And Casey, I'll turn over to you.
Thank you, Stephen. Like Stephen said, I'm Casey. I have the pleasure of running 51 Labs, which is Matter's women's health platform. And like Stephen also mentioned at the beginning of today's program, we're thrilled to partner with 7 leading organizations on this initiative this year. So thank you to HCSC, Laerdal Million Lives Fund, BayCare, Parkview Health, UChicago Medicine, Organon, and Stryker for your partnership on this initiative. I'm going to provide just a quick overview of this year's program. If there are any potential applicants on the line, please feel free to email me after if you have any questions. I'll have my email up on the last slide here. So to start, like Stephen mentioned, the focus area of this year's Women's Health Accelerator is how do we prevent maternal mortality in the US before, during, and after birth. The 3 key areas we're looking at are prenatal care, delivery, and postpartum support. Please note you do not need to neatly fit into one of these 3 tracks. You can operate across all 3, just 2, or just 1. So don't let that deter you from applying or not. This is a snapshot of where we are currently at in the process. Like Stephen mentioned, we are currently taking applications. We'll close just before midnight Central Time on Sunday, February 4th, so just about a week and a half from now. After that, we'll have a few weeks dedicated to review and selection, and then we will announce the 10 finalists who will be participating in the program by February 23rd. From there, those 10 finalists will participate in a 12-week accelerator that will have one-on-one mentorship with industry experts. We'll provide workshops and interactive roundtable discussions, forums, and more. The program itself will culminate in a final showcase that'll be in person at Matter in downtown Chicago on Wednesday, May 22nd of this year, where all of the startups participating in the program will have the opportunity to pitch their solutions to a live audience of key stakeholders, as well as a panel of industry experts. For those that are thinking about applying, this is really what we're looking for in terms of applicants. We're seeking entrepreneurs who are developing solutions that are working to reduce and prevent maternal mortality in the US before, during, or after birth. Applications are open to everyone. So though the subject matter, we are focused on the US, if you live abroad, you are more than welcome to apply as well. Applicants can be teams or individuals from across the entire innovation ecosystem. So whether you are a student, a clinician, a serial entrepreneur, a researcher, you absolutely qualify to apply to this program. And then lastly, we're accepting applicants that range from really early stage concepts all the way up through marketed solutions. So looking at a wide variety of stages for this program. The selection criteria that our review committee will be primarily focused on when looking at applications are detailed here on the screen. So first, the applicant's ability to clearly articulate the challenge statement that's addressed in the accelerator description and on the challenge page. Secondly, the quality, feasibility, and scale of the proposed solution or technology. Third, the differentiation of your solution within the competitive landscape. So what makes you stand out, what makes you different from your competitors. Fourth is the capability of you and your team to actually develop and execute against the solution. And then fifth, the ability of your solution to actually prevent maternal mortality in the US. This slide details the primary benefits that you would receive from participating in 51 labs. First and foremost, I want to call out that Stephen also mentioned in his opening remarks that for the first time, Matter is really excited to announce an investment component to this program. So if you are one of the 10 startups that's selected to participate in 51 labs, you'll receive an investment of $125,000, which is $100,000 in cash from the Laerdal Million Lives Fund, and then $25,000 worth of services from Matter. There's more details on what that investment piece looks like on our challenge website, so please feel free to check that out. In addition to the investment piece, participants can expect to engage with other cutting-edge startups, to network with peers and leading influencers in the space, to gain exposure to the Matter communities and the 7 partners that we're working with on 51 labs. You can expect to really hone in and refine your value proposition, to have that opportunity to pitch your solution to potential investors, partners, and clients at the final showcase on May 22nd. You'll graduate from the program with actionable next steps to really further advance your solution over the following 6 months after you graduate. And then lastly, you'll also receive a complimentary 6-month Matter membership. So like we mentioned, applications are open until Sunday, February 4th at 11:59 p.m. Central. If you have any questions, please feel free to reach out to 51labs@matter.health. Our more information can be found on matter.health/challenges. So please feel free to check that out as well. Thank you all for joining us today, for spending part of your afternoon with us. Thank you again, Stephen, Dr. Seitz, and Colby for your time and expertise. And I hope you all have a great rest of your day.